This conference will now be recorded.
Hello, everybody. I am Dr. Moseman here at Laureate in Tulsa. I'm doing a webinar today for you to watch at some point in the future, when you wish to. And the topic I'm talking about today has to do with obviously the passion that I come through here at Laureate. So this is about doing research in neurobiology. This is about being a board certified child and adolescent psychiatrist who does medication management in both eating disorder and non-eating disorder patient in my outpatient practice. And then sort of tying it all in, obviously with eating disorders and how those things interact. Certainly it's one of those difficult things where eating disorders really travel alone, and then trying to treat them depending on nutrition and age and those kinds of things can be pretty complicated. Sometimes the data is limited, so we're gonna at least go into what we know today. So yeah, we'll talk about psychopathology, how those illnesses work in these populations. That obviously comes with neurobiology, and we'll talk about how we treat them medicine-wise, and be specific about how that's maybe different in people with eating disorders. So we'll talk about brain development across the life cycle. Obviously a fascinating process. I have 3 kids of my own at home, and to watch sort of that process of how the different things work, abstractability, ability to, have a frontal lobe, put on the brakes, etc., as we develop all the way up into our early 30s, probably. Understanding the idea of neurodevelopment in eating disorders, right? So I'll sort of do a brief review. Those that hear me speak before certainly have heard me talk about the different areas involved in eating disorders. And so then, certainly as a child psychiatrist who works on both an inpatient, outpatient basis, to talk to you about, okay, well, taking these things in mind of normal neurodevelopment, development, how things work, then how do we choose which medications to use, and how do we look at clinical efficacy while they're used in the patients that we treat. So I think one of the primary questions is, so why neurodevelopment? So, what we know, if you look back actually in the Diagnostic Statistical Manual, probably until almost the 1970s or so, maybe up in the 80s, there's a sort of belief that like kids were just products of their environment, they were just products of their parenting, and the idea that they have this neurodevelopmental issues that cause problems was limited. I think ADHD being the most obvious one sort of comes on the scene, and some ideas about anxiety and mood disorders certainly have come on maybe in the last 30 years or so. So we do know that half of all adults had symptoms by the age of 14, and 3/4 by their mid-20s. So most of these symptoms are neurodevelopmental. How are we wired to deal with our environment as that weighs? My big thing to talk about right now is brain stress resiliency. So how are we born with brains that deal with stressors that life throw at us, whether it's pandemics or anything else that might come our way. And so I think that in looking at these early processes and look at these developmental processes can be important to determine, is there other roads we can take? So before things sort of become too hardwired, things might be more pliable and might be more changeable. They actually found this along those lines, since we're all just fancy mice anyway, they found this gene that, works on serotonin, and we'll talk about serotonin today, certainly important for anxiety and mood and eating. And it's a serotonin 1A receptor, and that they found that when it was lacking this, they developed anxiety, nervous behaviors in adulthood, like, they got all stressed out in the maze or whatever. However, if they were able to briefly turn that on in a relatively small window early in life, the anxiety behaviors did not develop. However, if they tried to turn it on later, they still develop to a certain extent. So there's a kind of thought of, we can recognize things earlier, whether it's through meds or therapy otherwise, is their ability maybe to cause changes that will last into adulthood. So as a result, there's this thing called translational developmental neuroscience, and this is the, through child psychiatry and those kinds of things. So it's interdisciplinary, like basic neuroscience, informatics, neurogenetics, cellular biology, physiology, psychiatry, neurology, all these kinds of things together to see sort of how do these puzzle pieces come together? How does environment and brain development come together to form what becomes a more static adult, where there are certainly those changes that happen along the way. Certainly one way that Laureate's part of that is we are one of the few non-for-profit hospitals that's part of the ABCD trial, where we're looking at 10-year-olds and we're looking at brain development and changes and over time to see and to add to this sort of course of information. So what do we know sort of in some broad strokes around neurodevelopment? So initially, first 6 years of life is just rapid brain growth, where there's overproduction of synapses, that sort of happen, so that actually gray matter, or the peak of gray matter, happens by age 10, with I think a majority happening up to age 6. And this starts to make sense as we look at meds, right? So I'm much more cautious with meds under the age of 5 and 6. You see much more side effects with meds when that brain is less developed and younger. And then by age 10 or 12, the brain starts to tolerate a lot more meds a lot more often. Gray matter hits that peak, and actually, lose some throughout adolescence and adulthood. And as that sort of gray matter comes down, what we see is an increasing myelination of white matter. It's sort of like, the brain is there, and then these sort of like connections happen. I mean, I think that's what you'd say would happen during, becoming an adolescent and adult. You learn to connect emotions with control of emotions, learn to connect processes together, abstract concepts, how they fit in your daily life, those kinds of things. That's also important because, white matter is mostly fat, right? And so certainly when you're having this right around puberty, especially, and then should a young man or woman get an eating disorder at that time, how that might affect brain development, or these sort of connections is very important. We talk a lot sometimes if patients have had eating disorder since they're young, that they're sort of developmentally stuck at that age, because they may be both from a development of just having normal brain growth, but even maybe some at a cellular level, their brain growth might get stunted. So again, when we look generally at the brain, and you just look at it, think of if you've had a kiddo that you've had as a son or daughter, a niece or somebody that's grown up. I mean, it's all about sensory stuff, right? Everything's in your mouth. You're learning how things work, motor stuff, learning to walk, crawl. That tends to be all the early things. And then higher level, prefrontal is organization, being able to organize and remember things. Limbic cortices is emotional behaviors and learning emotions and how to connect those two. And it's the connection, I think, of these higher cortices with sensory stuff, this integration that happens that gives us an adult brain that's capable of taking care of ourselves and solving problems. Now, pruning and synaptic elimination of synaptic spines happens through the third decade. So all the way up into the early 30s, especially prefrontal lobe development is really important, and important for our patients. In that prefrontal development lets them see bigger pictures and hopefully take care of anxiety and eating issues a little bit better when they can see a bigger picture. Emotional regulation is obviously in both eating disorders and psychiatry something that's very important, right? So it's this connection of what would be limbic processes, especially amygdala, processes of the insula and other kinds of things, and how they connect with the front of the brain, the brakes that lets you see the big picture and decide to make decisions. So we know amygdala volume increases between 7 and the age of 18, and the connectivity with this prefrontal lobe of our emotions and how we react to our emotions, eventually leads to this top-down control of emotions, right? A toddler just reacts to their emotions at the time, where I think as adults, we still have the emotions, but instantly that frontal lobe kicks in and decides, this is an appropriate place to display emotions. How do I display emotions? How then might they impact other people? That's especially, dorsolateral prefrontal cortex controlling and doing those things in therapy. That's what we're learning to do. We're learning to take these more advanced part of our brains and see if they can, down-regulate the more kind of primitive, emotionally reactive parts of our brains that can be brought up by anxiety, brought up by malnutrition, brought up by trauma, certainly all those things. So, the three systems is prefrontal cortex, regulatory control, and this is the ability of why teenagers do stupid crap, why you can't rent a car till you're 26, that you're going to have some ability to think before you act. The striatum is really, ventral and dorsal striatum are involved in reward, right? So approach and retract, right? So if you have very strong reward systems, as we see in bulimia, then approaching and wanting to do reward sometimes gets you, to feel better to the point of getting in trouble. Most time in anorexia, they have down-regulated striatum reward systems and up-regulated punishment systems, and so then their behaviors become more regulated by avoiding things that make them feel bad instead of chasing things that make them feel good. And so, that amygdala and how it works with the striatum is involved in that avoidance, that anorexics, everything is conceived as a threat, and then their primary mechanism is to avoid. So evolutionarily wise, I think, if you look at primates and those kinds of things, it sort of makes sense in some ways that when you have hierarchical living where there tends to be advanced males and those kinds of things that tend to have control over females, that if you're a young male or young, animal in general, then that ability to sort of be impulsive and go chase after things could actually lead you to take some risks and determine new territory, new other kinds of things, that risk taking early on makes some sense. And human characteristics, I think, understanding where your boundaries are and experiencing life gives us a better idea of who we are, what we like, what motivates us. And so being able to do some risks and not be so tightly regulated probably allows for some life experience and some things that can be helpful for us later on. And mechanism in the eating disorder, it's obviously, I've already sort of talked about that. It's reward and anxiety and stress, and then how our brains either temper that or don't, and how that sometimes leads to different behaviors. So the ways that we would see that genetically driven, this is a slide that I use a lot, is that when we look at the genetics of what somebody looks like that has anorexia, that what kinds of wiring they have before they ever got sick, it's negative emotionality, low self-esteem, which really drives their body image and really drives their anxiety, sense of perfectionism, and when they get anxious, they are harm avoidant, right? When they get anxious, they tend to try to make themselves feel better by avoiding any possible thing that might make them feel bad. Obviously, if that becomes lack of belief in themselves and body image, then avoiding food gains them some sort of control and makes them feel better for short periods of time. They tend to be more inhibited. They tend to have picky eating, probably going back to reward systems, right? And it makes it easier for them to go without food if food does not provide a lot of reward from them. Their interoceptive awareness, their ability to understand their stomach, we know that, especially in anorexia, they tend to have an anxiety. I see it in a lot of my patients that gets, because they don't recognize it very well, they have a lot of alexithymia or lack of, and it gets displayed in their body. So lots of stomach aches, GI, somatic issues, headaches, those kinds of things, basically leading to that belief of why we do therapy. Like if you can recognize and deal with your emotions, they're less likely to come out in your body, maybe less likely to come out in eating disorder symptoms. A lot of obsessive compulsive personality traits, order symmetry, again, I think an anxiety, keeping life very organized and very simple. But so lots of reward dependence. So a lot of our anorexic patients think that getting in the right college, doing the right thing, making straight A's will make them feel happy, but they run into low reward activity. It tends not to really end up paying off for them. However, if they do anything that is overwhelming for them or that gets them in trouble, that punishment is extra sensitive and probably leads to furthering on their behaviors. Where what we see in bulimia is still negative emotionality, low self-esteem, and these patients sometimes socially and otherwise are more capable than their anorexic colleagues, and recognizing too there's a large swath of patients that will go back and forth between these diagnoses. Tend to be anxious and fearful, also has some obsessive compulsive personality trait, but they tend to, I think when they experience anxiety, experience more impulsive, ability to want to feel better right away. So they have high reward reactivity, which ends up causing their mood to be really dysregulated, probably due to lack of connection to their frontal lobe too, especially as they're younger. I think we see in this patient population as they get in their 30s and 40s, as that brain development, should they be properly nourished and over time go well, that they're able to, do a better job of regulation. I mean, the same reason from an extreme set, like, if a toddler doesn't get something in the store, they can cry and have a tantrum. I think maybe I get close in Bass Pro Shop if that doesn't work, but I probably will, temper my reactions if something happens, as we get older, even probably as soon as being in your, 8 to 10 to 12 to 14, they might certainly roll their eyes and look angry, but they're not going to embarrass themselves. They'll think about the greater reaction. And that continues to grow in some levels as we get up into our 20s and 30s. Again, they tend to, however, generally have this impulsive lack of frontal lobe regulation, like how do I feel good as soon as possible? And I think that's some of the reason it leads to affective dysregulation. They get themselves in trouble, still have poor self-esteem, and end up on this roller coaster of chasing their behaviors and then chasing the reactions to their behaviors as well. So the sad thing is, one of the queens of modern neuroscience and development, and as long as most other things, Janet Treasure, this is an article, actually, sadly enough, I think it was done in the 1990s or early 2000s, when I looked to do this presentation on like, let's get a good neurodevelopmental model of anorexia. What do we think is happening early on with frontal lobe mechanisms and with what's happening? And there wasn't a lot. So I've kind of taken the paper down to some simpler elements. So first, at birth, kids got to be wired a certain way, right? So when we know that probably 95% of people are not wired to develop sustained, difficult eating disorders. Certainly, if you have anxiety, you might be sustaining some self-esteem or dieting or exercise behaviors, but maybe not to the point of being, symptomatic and problem in day-to-day life. In early childhood, again, because of the wiring, anxious, insecure attachments can tend to be dismissive, causes problem with self-reflection, identifying the emotions, which is alexithymia, impairment in emotional processing, leading to a sort of form of rigidity that life has to be that way. I'm not good at looking at my emotions, and so unless things work out a specific way, I get upset or overwhelmed, leading to perfectionism and stuff, which is great for school and great for getting your grades and goes in school. Not so good with emotional regulations when things don't go your way, or sometimes in relationships as well. So we know that they have heightened, corticotropin releasing hormone activity, cortisolemia, meaning that their cortisol levels, their level of alertness, their level of the amygdala going off when something bad might happen because of the punishment sensitivity, they'll tend to get these surges of stress hormones, which then certainly have effects on the brain as well. They tend to have serotonergic overactivity, we know, especially in the limbic areas of the brain, reduced amygdala and hippocampal volume. So they tend to have these things where their stress response is exaggerated, maybe recognizes this also would put them at higher risk of PTSD. In the little, arrow, if you can see this on this oval on the side, what does corticotropin-releasing hormone do when it is upregulated? It decreases sexual thoughts, decreased heart rate and blood pressure, slows, causes gastroparesis, decreased social interaction, exploration, decreased appetite, decreased pain. And we actually have studies to show that anorexics have decreased pain sensitivities and increased anxiety. These are things that we see in our anorexic patients all the time. Things that are further hampered if they have nutritional problems on top of that. So you can sort of kind of see how these things, whether chicken and egg, how they happen and make things difficult for our patients. So then you take puberty into that. So you take already this sort of rigid, lack of reward, avoidant, anxious, stomach-oriented patient, and then you just throw hormones. In women, I'll say that this neurodevelopmental model was made for women. The estrogen effects on serotonin and HPA, right? So most of my practice over the age of 12 are young women, under the age of 12 are boys. So, it starts to become, emotional regulation issues and problems that happen. Depression and anxiety certainly can get worse this time. Certainly the reason why, if those are driven, that it'll drive these avoidant behaviors, especially around food and eating, and certainly a reason why we see, anorexia nervosa and bulimia acutely worsening in the pubertal time. Again, a pubertal time where it's sort of worsening all these strong things without a really good developed frontal lobe to sort of, put on the brakes and make some alternative decisions to respond to therapy as well. And then over time, there becomes this, this positive or negative feedback loop, depending on how you want to look at it. Stress leads to worse HPA, which leads to, more problems, with how the brain responds, and less exploration and increased anxiety. And so it makes a higher sensitivity in the environment, which can certainly lead to more issues over time. So I always describe this as the world's worst slide, which of course then I have to put in my presentation, only because, I think anytime you hear somebody talk about neurobiology, impacts of body and microbiomes and all kinds of things, leptin, ghrelin, all these things that act together, a lot of times people will get really concentrated on, okay, people with anorexia have this hormone change. We're talking about, let's say, even corticotrophin releasing hormone. We're talking about a relationship with cortisol, but a relationship that extends out of how integrated all these systems are, how a problem in one system can lead to other systems. And then as we start not eating right or eating properly, how those further impact those systems over time. So this was actually a neurodevelopmental endocrine overview of what people thought that they saw in eating disorders and eating. So again, I think we just got to keep in mind that this is extraordinarily complicated, that, I think the days of coming up, both whether it's imaging or whether it's models like this, of really super complex computer algorithms as far as AI and those kinds of things. I think this is where we start to make a difference, where you could put this giant thing into AI, and then you can start to see how changes in one system might lead to changes in another. And then as we're looking very simply to change those systems, what might create, positive versus negative outcomes as far as sort of eating and stress management, et cetera. So I always go through this. So the cycle always will look at is we have these traits. These traits are really hard to change, right? Unfortunately, self-esteem, anxiety, those kinds of things tend to be, in a lot of my patients, lifelong traits with anorexia and bulimia. But then those traits are still affected by the environment, which is both internal and external things sort of influence that, and then can create an illness or not, which is sort of the quicksand is the weather in this case, and how things work when everything's combined. And that's the state-dependent stuff that's also affected by malnutrition or excessive eating, binging and purging, or drug use or other kinds of things that's not going to happen in bulimia. So to remember how all these things sort of work in eating disorders is important, because then when you layer on, okay, now are we talking about this in a 14-year-old or a 21-year-old or a 34-year-old, then that neurodevelopment is again another layer on top of that. What does their frontal lobe look like? How can they really respond? If I'm dealing with a 13 or 14-year-old adolescent program versus an 18-year-old, 17, 18-year-old adolescent program, how much their brains can really handle and do even if nourished, and then how much do I need parents to fill in that gap versus look towards autonomy in college. Like, these are still neurodevelopmental processes that are important for how nourished they are, how developed individually their frontal lobe and their ability to deal with impulses are. That all goes into a complex decision making to try to decide what follow up and what they're capable of doing, even when it comes to college and job and those kinds of things. So, at the end of the day, as a psychiatrist, probably the simplest part of my job, but it's still complex, is, as a child psychiatrist, I'm trying to figure out, can medicines be part of changing this giant equation to make a more stress resilient brain more capable of eating and existing in life. So just, so there's also, there's this idea of pharmacokinetics, right? So this is just the availability of how does the body process the drug. So not even talking about how very different the neural systems are in a 5 versus a 10 versus a 15-year-old, but just what happens to if you give the same drug to an adult or child. Children are not just mini adults. How do they react? And so in pharmacokinetics, what we know is because they're smaller, as you'd expect, this is the one, I think this is the common sense of one of what most people think, which is they're smaller, they weigh half of what I do, they should give them half the dose of meds. I wish it was that easier. Now we can see in fluoxetine that, yeah, that truth. Fluoxetine also happens to have the ability to have a very long half-life, so elimination stuff is not important for it. But what they saw is higher plasma levels in children than in adults. So you might need to keep that in mind with meds that last a long time, that the liver and kidneys not getting rid of, and then their body mass can become very important. Now, for most drugs for me, what I'm surprised by, as we'll talk about, especially liver and kidney stuff, is that because they generally tend to eliminate meds quicker and better than me than we do in adults, I'm surprised that usually like dosing doesn't look super different, between adolescents and adults. So one example is liver, right? So their livers compared to the rest of their mass are a more substantial part, and they'll actually get rid of a drug. In this case, this is talking about bupropion, which is Wellbutrin, and basically so that in a kid that gets rid of the drug in 12 hours, what takes 21 hours in adults, right? Where this can be complicated too is then trying to decide, well, do you need constant drug levels to get effect? Should I give a medicine like a Zoloft, which gets rid of quickly twice a day? But then if I take it twice a day, are they more likely to like not take it or miss it and not be compliant? So these are harder questions that we don't have great studies to look at, but their liver tends to get rid of things a little more quickly. The other thing is they don't have as much body fat, and certainly our patients generally, if you're anorexic, but even worse. And so the drug can't sometimes drugs build up in the body fat to get released and have better blood levels. So again, exposure, we don't have any studies to say that you have to constant Zoloft to create anxiety relief, but they're getting rid of the drug faster. So you sometimes have to watch for withdrawal syndromes can be worse in kids. Last is kidneys too. Their kidneys just work better than ours. And can get rid of things shorter. Lithium, which is obviously very important, mostly gotten rid of by the kidneys. The half-life is 18 hours in kids and 22 hours in adults, so especially something like lithium where there's toxicity levels, you got to be watching and careful. And obviously in our patient population, make sure that they're hydrated and those kinds of things so the kidneys can work as well. So these things are important as we're looking at it. It is certainly the reason it's important for me getting my MD and being a medical doctor and coming through all those, those classes I took. And I think the importance in child psychiatrists, I mean, in somebody who specifically studied these meds and can understand how they're different in a 7-year-old, a 14-year-old, and a 20-year-old can be important. One of the reasons at Laureate, where comorbid symptoms of depression and anxiety, knowing how this interacts both with their eating and developmentally, I think it's important to be a child psychiatrist to make those decisions. What else do we know? So the others is pharmacodynamics, and that's by like receptor binding. So once you have a certain dose that's not changed by the liver and other kinds of things, then like why sometimes adults and children don't react the same way. So dopamine, serotonin, norepinephrine, these receptors change a lot during development. So that drugs that work well in adults don't always work well in kids. Some drugs that work well in kids maybe not work as well in adults. Limited studies, but here's some stuff we know from studies. So the euphoric stuff that you get from caffeine, stimulants, obviously stimulants run from caffeine all the way to meth and cocaine, with Ritalin being certainly hopefully closer to caffeine along that line of things. But in adults, obviously this can be abused and can cause euphoria and make them feel good. That's less likely in children, right? So the worry about stimulants for ADHD causing euphoria is reduced. We know that in a lot of studies that the metabolic effects, weight gain, lipid changes, especially Abilify is a great example of this, where there's actually more likely to be weight gain in adolescents. And for me and my population, it's always trying to find out, like, someone has bipolar disorder, if they have resistant depression, when am I using meds that can affect hunger and carbohydrate cravings and weight? When I'm also trying to regulate getting somebody to trust meds, making sure they're at the proper weight, making sure I'm not inducing weight gain and causing them to have a relapse, or them just reading the blogs of worries about weight gain. And Abilify is a good example because I see a lot of my colleagues out there using a lot of atypicals in Abilify, especially on an inpatient setting, because a lot of times when their brains aren't really nourished, I don't know why, but I would say from a clinical standpoint of doing this for 20 years, I certainly see that some of these medications can be good in the short term of helping with affective dysregulation, anxiety, anger, where some other medications don't work. The question of how long you use it, is it still necessary afterwards? A lot of times the weight gain and carbohydrate craving stuff doesn't kick in until leptin levels are closer to normal, which is usually right at menstrual threshold. So when sometimes patients are leaving the inpatient side, and then they will get this big changes in appetite and in weight gain. So those things are really important to consider when you're passing off care and somebody else is inheriting it, trying to determine if we're using these medications on a short, medium, or long-term basis. We know that really young kids are less tolerate stimulants. So I know that if I give a 5-year-old Ritalin, there's about a 50% chance they'll have a side effect. If I give a 10-year-old Ritalin, there's about a 15% chance that they'll have a side effect. So there seems to be some differences in brain development and how it works. So sometimes medications that haven't worked when they're young can still work when they get older if the brain changes in a positive way, at least concerning that medicine. Hepatotoxicity, right? So we've got to monitor liver and obviously white blood cells and other kinds of things with valproic acid, which is Depakote. Higher toxicity sometimes in younger kids. We know, especially, there's some reasonable data with lamotrigine that it might be helpful for not only bipolar depression but unipolar depression. It certainly has less, hunger and other side effects, but it does have this propensity to rash, which sometimes can progress on to Stevens-Johnson syndrome. We know that children are at higher risks, and so we've got to be more careful with that in kids and sort of titrate more slowly and be careful of watching for that. Obviously, the biggest example, probably in the last 20 years, has to do with SSRIs and suicidalities in young kids. And what I would say is not just adolescents. We think this probably extends up into the early 20s. And so basically this FDA review, there is about 4% of those taking SSRIs experience suicidal thinking and behavior. And this is a true effect. So I don't want to say that somebody who prescribes these meds and people that have done these studies to say this is really overblown. It's not true. There seems to be something, and for me, I see it early in the process. So remember, with these medications, you change serotonin right away. And then the anti-anxiety, the stress resiliency factor takes time, sometimes 6, 8, 12 weeks. And for me, it's because you change that serotonin, but the reaction that gets you actually more brain stress resiliency is how the brain reacts to that change in the weather, change in serotonin. Now, the acute serotonin change in a small percentage of kids makes them nuts, makes them irritable and not feel good. If they have a tendency towards suicide, they'll get there. I haven't seen in my practice a kid who's never been suicidal all of a sudden get a medicine and become suicidal. But if they have a propensity towards self-harm and suicidality and you give them medicine that makes them feel worse, that can happen. And it usually happens right when you change that serotonin, which is within 24 hours of taking the dose, and less likely to happen. Parents always grab onto medicines in positive and negative ways. For me, it would be pretty rare that someone's on a medicine for 2 months and then all of a sudden develop suicidality. I think it's really an early serotonergic process that happens. So this study was true, and so the FDA looked at it, and so in 2004, there's a black box warning, right? And basically, pediatricians, there is only about 1/10 of the need of child psychiatrists across the nation. The average waiting list in the United States for a child psychiatrist is 3 months. Right? So there's just not enough of us around to take care of everybody who needs meds. So nurse practitioners, pediatricians, other people were doing a lot of SSRI use. When they saw this, I think without the training or other kinds of things specifically, they really backed off from use, right? And so the interesting thing that happened, right, is I think this is a true effect. You got to watch those first few weeks. You got to stop the medicine if it happens. Make sure you're keeping patients safe. There is studies showing if you combine it with CBT, you actually sort of mitigate out that suicide risk. But basically, there was a steady increase in serotonin and SSRI use, and there was a year-by-year dip in childhood suicidality rates. And then when the black box warning, there was actually a jump in suicidality rates. So it's always that, yes, there can be this side effect, but the side effect of untreated depression and severe anxiety is suicidality, maybe even greater risk than the smaller risk of starting a medicine and watching them carefully. So, you know, and there is the Lexapro study, which actually seemed to show the escitalopram or Lexapro less of this irritability or suicidality effect. So again, it's about, there's something different in these brains and how they react to serotonin. And you got to watch the side effect. It's a real side effect. But remember, I mean, this is what I tell my parents so much, especially those ones that are really worried about meds. I'm pretty conservative in how I do meds, but telling them, you know, untreated depression, anxiety, eating disorders, they can have awful consequences, right? So suicide and you know, life experience and how it affects school and relationships are very real and can be very sustained. And so always balancing out benefits and side effects is important. Starting meds, watching them carefully. I'm seeing almost all my young patients back within a matter of just a few weeks, and telling them, you know, contact me in this first week if something gets, I always say, if there's something more than mild that happens, just stop it and let me know. If you stop it, the effects should go away. They don't just make somebody suicidal, and once the medicine's there, it'll go away unless that medicine is irritating them and is on board. So what else do we see developmentally? So ADHD is something that we certainly see common, especially before the age of 12, you know, especially a reason why most of my practice under the age of 12 is boys. So it's certainly a neurodevelopmental disorder that has to do with frontal lobe development, right? And our frontal lobe's ability to make us stop and think and calm down and not move so much is not working in this population. It's interesting to see, you know, development happens from simple sensory, even in the womb, simple sensory stuff, then some limbic stuff, and then frontal lobe stuff is last, probably representing evolution. And then, you know, those systems continue to grow in that level until we get to our 30s. So an interesting thing is that in preemies, you know, we know there are studies in really, really young kids, if they're like less than, you know, delivered, especially at less than, you know, 32 weeks, definitely less than 30 weeks, that their rates of ADHD are like 2-3 times the general population. I think because that frontal lobe is like the last thing to cook, it's the last thing to develop, and if they don't have that important uterine development and they're delivered early, there can be higher risks. So again, development both in the womb, outside of the womb, continuing makes sense. And what do stimulants and Ritalin do is really this default mode, you know, that kind of makes them act before they think. It sort of downregulates that leads them to be calmer, and leads them to be able to have less attentional lapses. And then also too, with my younger kids, especially if they have anxiety or emotional issues, there's always that issue, and I see this in a lot of my eating disorder patients, of trying to determine if you have somebody with brain stress resiliency and anxiety issues, and possibly impulsivity and ADHD issues, of which one's which, right? These emotional issues I'm treating with SSRIs, therapy, exposure and response prevention. ADHD is really a medicine thing. It is really a Ritalin stimulant thing. Like a lot of the therapies and stuff really they're not going to calm your kid down or make them be able to sit down and do their math work. Stimulants for ADHD symptoms can make anxiety bigger and worse, right? So always looking at this balance, especially in young females, right? So ADD is so fast, grades aren't good, you want to get their grades better. Anybody concentrates better on a stimulant. And so you sort of, you know, if anxiety is making that brain harder to concentrate, if you hold up that frontal lobe, they'll still be able to concentrate better, but is it getting to the primary problem? And so this is one thing I see in my practice, eating disorders, not eating disorders, is trying to determine how much emotion, how much breaks are involved. My eldest kid is 15, he has both. And so understanding sometimes needing treatment for both of those can be important as well. And getting that accurate diagnosis and seeing how they respond to meds, making sure if you put somebody on a stimulant who's having concentration problems at school, that the concentration problems are because they're worried about their body image all day
and then you give them a stimulant, you could make them more anxious and then not eat, and could make their eating disorder worse if you don't have the correct diagnosis. We also use atomoxetine or Strattera, which works on norepinephrine, where these other medications are really working on the dopamine circuit. And it tends to work and can help partially with anxiety. And so it's another mechanism for trying to help that frontal lobe work better. Guanafenicin and clonidine, these are also Intinib and those kinds of things. These are alpha-2 antagonists. This can help with sleep. It can certainly help with just sort of down-regulating some of the over-regulated nature of them. And again, I've already talked about eating disorder stuff. For me, it's always making sure that the concentration problems aren't due to depression and anxiety. And then it's looking at, is this person using a stimulant to suppress appetite? Is it going to make their anxiety worse? How do we balance that out? It's not uncommon that sometimes I'll try some Strattera in my patients who are acutely recovering. If it works, great, because then it works 24 hours a day, 7 days a week, where stimulants really work like Tylenol. They work while they're in your system for a matter of hours. And then if they're well enough and it's not working and it's clearly their anxiety stuff's better and it's clearly ADHD stuff, then I think using stimulants carefully as long as they're eating can certainly be okay. But again, imagine this. So if you have a patient who's in the hospital recovering from anorexia, they've been diagnosed with all kinds of stuff, and they're on, Abilify or Risperdal or Zyprexa, which increases their appetite, or Depakote, which causes carbohydrate cravings, and then they're on a stimulant, which suppresses their appetite. And then you're trying to get them out there. You're trying to teach them intuitive eating to understand their meal plan and trust their meal plan and listen to their body signals. Those things can create complications. Not treating the depression and anxiety certainly creates complications. So having a team approach, having somebody who's capable in understanding development, eating disorders, and neurobiology is important before making complicated decisions around medications. What else do we see developmentally, right? So, first of all depression is not the same in teenagers, right? So our patients sometimes don't recognize their anxiety and depression, a lot of alexithymia. But then instead of being sad and tearful and those kinds of things, a lot of teenagers tend to have more irritability, more lack of interest in things, more somatic symptoms, headaches and stomach aches, and then decline in function, like all of a sudden grades or activities going downhill. And what we know in teens is like Prozac or fluoxetine, sertraline or Zoloft or escitalopram or Lexapro probably have the most data, and they have FDA recommendations in teenagers. When they did the TAD study, which is a teenage depression study, fluoxetine, 69% response, CBT, 65% response, combination, 85% response. And this is important too, right? Some people don't want to take any meds regardless, and it's like, well, you're possibly limiting a response if you have moderate depression or anxiety. Some people just want to take meds, and therapy is too hard or too expensive, too many copays. Again, now you're talking about 69% response, so that combination is important. What's interesting about teens and not being like adults is that in adults, and I deal with a lot of severe depression, resistant refractory depression here together with eating disorders, is that in adults, the kind of course of events is try SSRI. They have the least amount of side effects, especially compared to the old medicines in the 70s and 80s. And then if that doesn't work, since it just works on serotonin, SSRI stands for serotonin selective reuptake inhibitor, you try SNRI, serotonin norepinephrine reuptake inhibitor. So a bigger bomb hitting more neurochemicals. And in adults, that tends to lead to a higher response rate and a higher remission rate, which is the importance I took of medicine that made me feel pretty much almost all the way better, not just half better. And so they did this Tordia study, actually happened in Pittsburgh where I trained. And when they looked at it, and they, you fail on Prozac, and then they put you either just on another SSRI, or they put you on an SNRI, which would be like Effexor or venlafaxine, or Prestige, which is desvenlafaxine, or on Cymbalta, they really saw that there wasn't a big difference choosing a second SSRI versus SNRI, right? Now here's where it gets really complicated. What we know is these noradrenergic systems seem to develop later, like mid to late teens to early 20s. So no studies I can say, but I can say in my clinical practice, because it's not uncommon that I get patients who've tried all the SSRIs and they haven't worked, and they have really bad depression, and we're not wanting to move to big atypicals with side effects, is that sometimes I think there's a distinct difference of a 11, 12, 13-year-old and maybe like a 16, 17, 18-year-old. I've had some 16, 17, 18-year-olds that can do well on a Prestige or a Cymbalta that, nervous systems are probably different from individual to individual, but as they start to develop, these meds sometimes can provide an advantage, but might be a difference in advantage in a 13-year-old versus a 17-year-old, certainly versus a 24-year-old, and that it's a continual growing process, not an on and off switch. We also know that ADHD, OCD, conduct, PTSD, they all affect response in kids when to meds. A lot of times the eating disorders, I have multiple ones of those going on at the same time, as well as malnutrition, like when you're not eating, the meds don't work. So it's super important for eating disorders and looking. So for me, it's always, gosh, I need that brain to be nourished. I need it to be able to use therapy and do things. And then, we're putting the meds on. Sometimes it's not until months later. Sometimes it's not until I try to come off meds because they've been doing so great. And the only thing you're changing is that med. I'm in weight range and doing great and life's going good. My period's fine. I don't have problems. And then I try to take them off the Prozac or reduce the dose in half because they want to take less meds. And then they're like, oh, wait, that was working. Like I'm more irritable and then we can always put it back on. Sometimes it's not until, because we're doing so much in the acute treatment phase, it's hard to tell what's working or not, but later on you can see for certain individuals that really provides some brain stress resiliency for them. Bipolar disorder. So, my other area of interest, probably in my training and development before I got here to Laureate, was in childlescent bipolar disorder. So what's interesting is you go back to the history of bipolar disorder in the 20s when Kreplin described when they had no meds, he just described these patients and some spontaneously got better and how their episodes looked. It certainly described the process that we see with more manic episodes in the teens and 20s and then more sort of depression and other problems as they get older. But even he back then described that 38% of his patients had onset younger than 20 years and a little less than 1% had onset before 10. Now, when I worked at Pittsburgh, so in the 90s, there started to be this idea that even kids could get bipolar or not, right? They did this study where they saw, again, it was in Dallas, and they took like people with adult symptoms and asked about sleep and other kinds of things, and we're seeing they had symptoms. And why this is important is there's a process in bipolar disorder called kindling, which means the more episodes of depression or mania you get, the worse the illness gets. You add drug and alcohol, other things which are common. Half of people with bipolar have that problem. And it just makes it a more tangled mess, a more knot of things. It's more difficult to resolve, whether it's meds or proper sleep or therapy or obviously the combination. So we can kind of see that, like, if this happens, it can happen in kids. Defining that is still difficult, right? I unfortunately in certain settings see a lot of over calling of bipolar disorder. And when the meds are lithium, Depakote, atypical antipsychotics, which especially affect carbohydrate craving and hunger and weight gain, and in individuals that we have that already have labile moods and those kinds of things, like trying not to muck up the waters by making an improper diagnosis and then putting a medication, which makes hunger and intuitive eating processes, is an important one. So certainly lithium has been used for a long time. It's the only medication ever seen to reduce suicide. It can be used in bipolar disorder. Kidneys, hydration, those kinds of things are important. Depakote, you could treat childhood bipolar disorder with that as well, and atypicals. And then there's also studies of unfortunately, sometimes depending on severity of bipolar disorder, sometimes cocktails or mix of drugs are necessary to more completely take care of symptoms where somebody can sleep and go to school, stay out of the hospital, stay safe. And eating disorders, again, making sure you have a proper diagnosis, making sure that mood lability, making sure that anxiety, which can look like racing thoughts and sleep problems, are not mistaken. Because the problem is that, let's take an atypical antipsychotic, like olanzapine has a lot of properties which makes it sedating and anti-anxiety, right? And so you'll put on this medication for somebody's anxiety driving their mood all over the place, and it chills them out and makes them less anxious, and then their mood will be more stable. Well, and then you'll say, well, their mood was, bipolar and unstable, and now it's stabilized because I put them on a quote unquote mood stabilizer. Well, it could have been you just started olanzapine and you treated their anxiety, right? Could have been that you could have put them on, a little bit of Zoloft, and over time made sure they're properly eating and doing their therapy and not drinking and doing impulsive activity, and they could just have just as much relief with much less side effects. So again, to not underestimate the importance of a really good and accurate diagnosis, history of how they react to meds, making sure they're properly nourished, that all these elements, just like in that crazy drawing, affect each other, and the proper, the possibility, even after 20 years, I'm humbled, in the fact of difficult cases and using psychological testing and getting to watch them in the hospital over time to see how they react. Now the ability that I've had patients who are treated when they were 12 and they're 26 now, to see how these things grow out and develop, to watch borderline personality disorder become nothing as they get in their 30s. Neurodevelopment's important, understanding the layers of those symptoms. How old are they? What are their symptoms? How's their nutritional status? Like, you start to look at things, well, you have this problem, you need this medication, is really a simple and non-scientific approach that doesn't do the patient any good. Anxiety, OCD. So this is certainly huge in eating disorder patients. Again, as in depression, puberty, estrogen, girls are 2 to 3 more times likely to get anxiety disorders as adolescent. That estrogen hormone really adds an element that makes things harder. Anxiety is the most common disorder, right? 15 or 20% of the time. It's also one I think that gets missed the most, especially in our population who are lexothymic. And I'll see an anxious perfectionistic girl and I ask them if they're anxious or stressed, and they'll be like, no, not at all. I'm not an anxious person at all. OCD is about 1%, but it's much higher in anorexia. So especially in the eating disorder population, we're seeing this a lot. It's the most common thing in general when I see kids, and I like to make it bigger. Brain stress resiliency. How does your brain deal with it when it's thrown a curveball? How does life work when you're thrown something that doesn't work? How flexible is your thinking? How ability do you have to think around things? Still using SSRIs. Duloxetine, which is Cymbalta, was also approved in 2014. Anxiety in all my patients, but especially kids and especially eating disorder patients, benzos, Ativan, Xanax, clonazepam. More behavioral disinhibition, right? Especially important in your impulsive patients, right? So I'm super anxious and I get impulsive, and when I do, I kind of lose it and break something, throw things, do those kinds of things. Common thing people reach for is Ativan, right? Chill you out, those kinds of things. But for some of our patients, especially some with what used to be cluster B or disinhibited borderline traits, it's a possibility that medication will actually make it worse, right? It makes you more disinhibited, similar to alcohol, and worse in kids than they are, and even in adolescents and young adults. So you got to be careful with that. I have found for my eating disorder patients around meals, hydroxyzine, Vistaril, which is sort of almost fancy Benadryl, is just about as effective as benzos with much less side effect and disinhibition. So why not use a safer, easier thing? Buspirone or Buspar is pretty safe, right? It's a selective serotonin reuptake inhibitor. I certainly use it a fair amount. It's kind of a pain that you got to use it 2 or 3 times a day, so compliance can be an issue. But limited trials in children, but probably doesn't have as much harm, as safer than certainly some other meds. And so in eating disorders, A, where's their nutrition? B, how's their anxiety and how am I treating it, over time? And, and this is a huge one, right? Brain stress resiliency, anxiety, and eating disorders are huge. They underlie it. They tend to go past it. And so sometimes using meds to help with that can be helpful for both the medium and long term. Nutrition, right? So I've already described what happens when we're malnourished. Well, no serotonin, right? So we know that food decreases serotonin synthesis in the brain. You need tryptophan to make serotonin. We know that, let's say in women, less estrogen reduced in the starved state modulates serotonin uptake, so it doesn't even take the serotonin up. So what I say is, if you're amenorrheic and you're underweight, A, you don't have a lot of serotonin to work with if you're using Prozac, and B, then it doesn't even get uptake back into the neurons very well. So you're just sort of missing out on the point of what's creating the change. And so medicines less than 90% of ideal body weight don't work well. So when I go through, if somebody's quote unquote failed medications, the question is, did you take big enough a dose for a long enough period of time at the proper weight, at the proper nutritional status if you're talking about eating disorder patients? Because if they tried something at 75% of ideal body weight for 3 months, even if it's good dose, I can't say that that's still a failed trial. A failed trial means all the situations were correct, they were compliant and took it, and then it caused a side effect or it didn't work. We know CSF concentrations are low, and here's the other thing is, for so many of our patients, this malnourished state, this low state of serotonin, which sometimes makes them numb and in some ways less anxious, that's maybe some of the reasons why they do it, also can lead to higher risk of suicide, right? So your patients that are the most malnourished are probably at the highest risk of suicide too. So it's a lot of things, and then you can't just treat them by throwing on some Zoloft if it's not going to work correctly. So the process, that's why the process, if you have somebody that's underweight, of doing proper nourishment as a baseline foundation is so important, because nothing else works until that works. The other is folate. Folate's important to make serotonin, norepinephrine, dopamine. Even if your MTHFR system works right, which in some women it doesn't, it's important to do and supplement if that's not working right. But even if it does work right, if you're malnourished, folate's off, you're also not producing monoamines. Like, these medicines just don't work well. You're going to stop producing the chemicals you need for your brain to work or for the medicines to work on. Other things that we use, like, again, we're treating comorbidities. My team always jokes with me because I always say, gosh, is there anything else we can do? And I'm like, there's no anti-anorexia pill. Like, she has really bad body image and anorexia, and I don't have that pill. But treating comorbid anxiety, if they're properly nourished, can be very important. Topiramate, naltrexone for purging. Topiramate, sometimes you got to watch for side effects with weight loss, and you got to watch for side effects with cognitive slowing or dulling, word finding difficulties. Naltrexone is obviously that thought that, especially in binging and purging behaviors, if there's, just like alcohol, there's this endogenous opioid release reward that happens that's opioid in nature, and if you can stop those opioid receptors, they don't get the reward, maybe they do the behaviors less. For me, these are sort of Hail Marys. Like, they're not really substantive for a large majority of patients, but in patients with more severe behaviors who have tried lots of things, trials of these medications, if they're carefully monitored, can sometimes result in improvement of symptoms. Oftentimes what we know from naltrexone studies in alcoholism is that if you're eating correctly, unless you're binging and purging, unless you're doing the behaviors and not getting the reward, they don't work as well, right? And we live in such a recovery, not harm reduction, but in a complete sobriety mechanism. Those meds don't work well in that mechanism. If you just don't do them at all, you can't not get the reward from them. The meds don't work as well. And the naltrexone studies, they showed in people that continue to drink, they would drink less, and they would, have less pass outs and, less severe drinking episodes. But if they were completely sober from an AA, they didn't result the same reports. So it's always making sure that the mechanism works with whatever system it's in. Prozac, lots of studies in bulimia around reducing binging and purging. Vyvanse and binge eating disorder, this is working on dopamine. This is a stimulant. We've talked about stimulants in ADHD. Yeah, I guess if you're impulsive and have some, issues that might help, I still have asked for those in the company and those kinds of things. Prove to me why this is, in short-term studies, getting in the way of binge eating disorder other than just suppressing appetite, right? So I think that's an important mechanism in how we look at things and how things work over time. So as we look at things, here you can see sort of my references. Here's some good articles, additional resources from the internet that we can look at and do. I think, the closing information is that, I love my job. Certainly you can sort of handpick how many, child psychiatrists across the country who are doing dedicated daily eating disorder work. They're wonderful people, because you're dealing with, I always say, doing, psychopharm and anorexic or bulimic adolescent is like, data-wise, is like trying to fly, blind in a snowstorm with, no GPS. I mean, there's not a lot of studies to base things on. You got to make those decisions as far as caution and doing no harm as trying to help people who are really desperate for help. And so, and I think the understanding of how the development, how the neurobiology, how the nutrition, and then specifically how the medicines work and work in those bodies, like taking all those elements and coming up with good pharmacology is complicated. the last element I'll go over, because it's come up a lot for me recently also, is now genetic studies, right? And so I think what I'd like to say about those is information is always good. Right now, that's not always paid for by insurance. Most of these genetic studies are really not looking at receptors and the chance that a medicine is going to work or not, right? And to simplify, they'll put them in sort of green, yellow, and red kind of things. I think what's important is they usually tell how a medicine is metabolized, right? It's usually the P450 system in the liver. And if somebody is a super fast metabolizer and you failed on Prozac, it might mean that you just need to use big doses, right? Because they're chunking through it really fast. So it can be important for that. I tend not to use them unless I've had failures. They can certainly predict MTHFR, which is folate metabolism, to see if you need Deplin. They can sometimes predict if you're going to have a higher chance of a rash from things like Lamictal or Depakote. There's some things, but they're not taking the place of the complex things of looking at the diagnosis, development, and the big picture. It's basically your baseline genetics. Most of it's how you process meds, and it's not. If the process of choosing was getting a blood test and saying that Prozac's going to work 90% of the time, you wouldn't need me doing what I do. You'd need me for other things. Not that the information is not important, but that it doesn't take the place of clinical information. My hour I have is up. Thank you so much for being with me through this. Hopefully get hold of Lauren or Heather or any of our admissions department. My email is always open. Happy to work with colleagues. Happy to answer med questions, even if you decide not to pursue things here for treatment. I think we try to be collegial and work together in the eating disorder field, which I love. So please shoot me an email if there's questions. Please shoot me questions, and thank you so much for your time.